Our next speaker is Dr. Constantino Pena about DES, when and why.
Hello, good morning. First, pleasure to be here. Appreciate the invitation and a great job by the organizers. It's really been a great meeting. So, drug-eluting stent, when and why? I always tell my fellows that when you place a stent, it better look good because that's basically the best it's ever going to look. And when you come back, you may end up with this type of feeling. And this is basically the Achilles heel of stenting in the SFA, and that's Neointimal hyperplasia. As we've already heard, the drug elution has really revolutionized the way we treat our patients because of its effect on intimal hyperplasia. Borrowed this slide from Bill Gray and basically talking about that cascade in that SFA. As we treat that vessel, we get immediate crush injury to the plaque, and then you have that signal platelets, fibrin, that leads to that neointimal proliferation. We talk about 6 weeks onward after we do our intervention. And really, this is where drug elution has helped us. What does DES provide? What's the dream? How does it help us? I think it provides that mechanical scaffold along with a way to give that drug elution, provide and give us that drug to help that intimal hyperplasia. United States, we have one stent system, drug-eluting stent that's approved. It's the Zilver PTX. So I'm going to spend some time talking a little bit about that, and then we'll discuss a little bit about the future on what's coming. And basically what we're looking at is really Paclitaxel eluting stents. We've already seen and heard about the data with Zilver PTX, and I think what's important in the take-home message here is that the amount of data that exists for drug-eluting stent is significant. Really, when you look at all the technologies we have, that amount of studies that have been done and different factors really is something that we should really look at, and it's impressive, especially in this space. When you look at Zilver PTX, the initial data looking compared to angioplasty, whether you looked at all patients that had angioplasty or only those that had successful angioplasty in the way that study was created, you can see that it was significant in terms of the effectiveness over angioplasty at 12 months. When they then also, because of the design of the study, compared it to the stent protocol, right? You had angioplasty, that angioplasty wasn't sufficient or wasn't a good angioplasty, then it would randomize to a Zilver PTX versus a regular Zilver or nitinol stent. So when you looked at provisional bare stenting versus provisional Zilver PTX, also saw significance in terms of the patency at 2 years. 5-year data. Again, I think that is so impressive. I think when you're looking at these technologies, I think what we've learned is that 3 and 5-year data is going to be interesting and really important as we make these decisions. You see here, looking at Zilver PTX over optimal PTA and bare metal stent, you basically have 48% reduction in reintervention. But I really like to look at the clinical benefit, and I think that's also very important. Sometimes we get caught up on patency and TLR, and we really have to look at really surrogate endpoints of how well our patients are doing. And I think we see here in terms of clinical benefit, you see significance in terms of PTX versus optimal PTA and bare metal stent. Again, looking here at worsened claudication, rest pain, ulcer, and tissue loss, which I think are important. When you're looking, again, that amount of data, and you start looking at almost over 2,500 patients that have been enrolled in different types of pre- and post-market studies. You can see that randomized controlled trial in itself was significant in the number of patients that were enrolled in the design of that study at that time. But you see now being able to do more and more studies where you looked at single-arm studies, which involve Canada, Europe, and Korea. You look now at the Japan post-market trial that started looking at more complex, longer lesions, including the popliteal artery, and as well as in-stent restenosis, and other types of studies that are being part of the global clinical program. I think what you see is you see longer lengths of lesions, you start seeing in-stent restenosis, and you start seeing sicker patient populations that we're able to get some information from. So just looking at these different studies, you can see now you're leading longer lesions over 15 centimeters at the average length in the Japan post-market trial with over 900 patients. But again, what's important is that TLR, again, seems to hold in these studies. Again, 2 years. Hopefully we get more data out of these single-arm studies. We've already heard from the bare metal stent and that whole thing of the integrity of the stent and stent fractures. I think we're now looking at better stents, better stent technology. It's not only the fracture rate, but how easy is it to deploy our stents and how accurate are we when we do deploying the stents. I think these are all important. I think we've seen that in terms of the Zilver data, low fracture rates, and we can hopefully continue to see less fracture rates with the technology that we have. So what other information have we gleaned? I think some of this data helped us look at longer lesions. And we've seen longer lesions now with drug-coated balloons. There's also long lesions looking at, hey, it really doesn't, not a big difference when you're looking at lesions longer than 10 centimeters versus less than 10 centimeters when you look at the Zilver PTX data. Also looking at diabetic patients. Other studies have focused on in-stent restenosis. There's a lot of studies now coming up looking at real-world analysis, drug-coated balloons versus drug-eluting stents head-to-head at 2 and 3 years. And those publications will be coming out of Europe, hopefully in the next year or so. What else is there and what else is coming? In the United States, the Eluvia stent is not approved. We just finished enrolling the IMPERIAL study, and we'll talk a little bit about that. But this will hopefully be another stent that we'll have to give us in terms of drug-eluting stent technology. Again, it's a nitinol stent, but this does have a biostable polymer that helps elute the drug, and we'll discuss a little bit about how that's different. And I think when you're looking at drug-eluting stents, just like you're looking at drug-coated balloons, they're not all the same, right? Every single one is going to be different, and how do we assess that difference? And is there going to be advantages of one over the other, and when are we going to use them? When you look at this type of Eluvia type elution of the stent, because of the polymer, have a longer time and a smaller dose concentration, but for longer time of giving the drug. And what will that do to the results? They had the results of the MAJESTIC clinical trial done in Europe, single-arm, a multi-center study of 47 patients. And what was interesting with that is basically that they showed the safety, and that led to that IMPERIAL trial, which, again, it's completely enrolled. Hopefully we'll have results by March of next year, and basically 2-to-1 randomization with against the Zilver stent. Basically, it's a non-inferiority study, which I think is a great study design. So basically comparing it to what we have now, which is approved as Zilver PTX. So in conclusion, drug-eluting stents, the advantages combine scaffolding and drug elution. I think it's an excellent result for a variety of lesions. It's easy, and you get durable results. Disadvantages, again, dealing with the stent, and I think we've got improvement with that, and then dealing with costs. Stent length and costs, I think, is really some of the disadvantages of this type of technology. When do we use drug-eluting stents? I think we favor drug technology as best we can. We like to go with balloons. We use stents when they're longer lesions. We like drug-coated balloons with smaller lesions that are minimally calcified and lower Rutherford class. I think when you start looking at Rutherford class 5, I may go and go toward a scaffold. I think the times we don't use drug-eluting stents are patients that can't tolerate antiplatelet medications or patients that we have a scaffold across the popliteal artery. There we try not to put a stent if we can. If not, we'll use for an interwoven stent. But I think we've already heard here the importance of dissection, recoil, and calcification, making these decisions. And I don't think you need to make the decision before you start the case. A lot of times people make the decision outside the room or when they have access. I think you go ahead and you're going to angioplasty this lesion first and see how it reacts, and then you can make a decision. Do you need a scaffold or do I need a drug-coated balloon? So I think our technology is improving. Drug elution, without a doubt, is here and something that's changed our results. Incredible amount of data for a drug-eluting stent with Zilver PTX. And future technology will hopefully be promising. And these direct comparable studies, I think, will also be very helpful as we move forward with our data. Thank you very much.
Thank you, Dr. Pena. That was a great overview.